The RESONATE trial provided new information on a new class of drugs, Bruton tyrosine kinase inhibitors, for the management of patients with CLL, both in the induction phase and in the relapse. RESONATE studied ibrutinib or Imbruvica with chlorambucil versus chlorambucil alone, very analogous to the study that was done with obinutuzumab plus chlorambucil versus chlorambucil alone. But what was notable about RESONATE is that it provided an all-oral therapy regimen for a condition that previously had been treated primarily with IV therapies. But interestingly, the outcomes of the RESONATE trial weren't dramatically different than you saw with obinutuzumab plus chlorambucil. Both had hazard ratios for overall response rates or progression-free survival that were in the 80%. And so it provided another option for providers who wanted, and for patients who wanted, an oral therapy. I think that's the main take-home from RESONATE, was the ability to provide that all-oral regimen. The advent of oral combination therapies for the treatment of CLL provides obviously new therapeutic regimens for both patients and providers. How will managed care companies oversee that? Will we have preferences for the cost of care? Certainly, we are concerned about the cost. Today, most health plans have guidelines that are in place, at least prior authorization guidelines, to ensure that the drugs that are being used or the combination therapies that are being used are consistent or adherent to the NCCN guidelines. But today, most health plans don't have preferred agents in place. We don't require one drug over another in almost any cancer type, and that would include in the CLL space. But given the dramatic cost and differences in cost between some of these regimens, the question is, when will the straw break the camel's back? What's very interesting is with the advent of the CMMI, or Center for Medicare and Medicaid Innovation, and their oncology care model, will that drive providers' behaviors in choosing different therapies? So for example, obinutuzumab plus chlorambucil costs about $50,000 for a 24-week induction, and then you're done. For patients who are getting Imbruvica or ibrutinib plus chlorambucil, that's induction therapy plus maintenance until progression. Dramatic cost difference, $160,000 a year. So while we as a health plan today aren't ready to take that plunge and require one therapy over another, it's certainly going to be imperative for physicians to consider the cost and the outcomes differentials in the future, especially as they become increasingly accountable both for costs and outcomes. So how will ibrutinib be incorporated into the treatment pathways? It has an indication in almost every clinical subset. It has an indication for the frail and elderly. It has an indication for those over 70 or those younger than 70 with complications. It has indications for those under 70, and it has an indication for patients who have a high-risk P17 deletion. So I think if providers wanted a drug that they could go to in almost any clinical circumstance, that certainly has the broadest number of indications. Although I would say that there still are other therapeutic options that exist for those under age 70 who don't have comorbidities. FCR is still the standard of care and is dramatically cheaper. I can't imagine that a physician would use that, nor would we as a health plan allow it. So I think the increasing number of studies that are available to demonstrate the efficacy of ibrutinib will certainly expand its use and potentially as a first-line agent.